Good afternoon, everybody, and thank you for joining our call today. This is the first in a series of what we're calling Infinicast on Occupancy and Outcome Advantage web series. Today we've got Jake Arastia here with us. He's the Vice President of Strategy Development and Innovation for Infinity Rehab, and we're excited that you've joined us on this call. We understand the healthcare environment is changing rapidly, and in the past few years, Infinity Rehab has been developing a lot of new competencies to help its customers with being successful in these new environments. So we're excited again that you've joined us to hear this very first first presentation on the series. And today we'll be talking about marketplace intelligence and really knowing how to position yourself in the market using data. So I will turn it over to Jake. Thank you.
So hi, good morning, everybody. Thank you for joining us. I know we're all busy, so really appreciate if you could join us this morning. Just a few reminders. First of all, if you can see the chat window here, towards the end of the call, we're going to be taking questions. The only way you'll be able to speak up is if you've actually used your audio pin when you logged in for the call. So please make sure you do that. On the other hand, if you don't have that, you may post your questions on the questions window of the webinar, or you can type it directly on the chat window, and we will be addressing those questions towards the end of the call. So that said, let's move forward. So our topic today is, how to use market intelligence data in value-based reimbursement environment. And what we're going to do is we're just going to frame up the situation a little bit with respect to value-based reimbursement. But more importantly, we'd like to show you a data solution we've been developing in Infinity with the intention of really sharing it to all the Infinity customers so that you can take advantage of your market position and how you may use data to better position yourself with your upstream partners, meaning people that refer to you. So that said, I'll move on. So before anything else, I think when we talk about value-based reimbursement, it's always helpful to define what is risk and what is an opportunity. And to that end, there's different ways of defining it. What we like to do is say risk as something that's uncertain, meaning you don't know if you're going to get, you don't know the potential for financial loss or for return. An opportunity being something where a set of circumstances that make it possible to do something. So kind of in a nutshell, if you're in a position to have the information you need, then you mitigate the risk. But more importantly, you're in a position to seize an opportunity that may present itself. That said, let's review all the information that may be helpful to mitigate our risk with respect to value-based reimbursement. First is framing the situation. As we all know, over the past couple of years, Medicare has set aggressive goals on managing Medicare costs better. In fact, these are actual goals they've set out a few years ago. The first one is making sure that 30% of Medicare beneficiaries are in alternative payment models. The next one is that 85% of all Medicare fee-for-service payments will eventually be tied to quality or value. Now, how Medicare has delivered on that promise is through a series of regulations and payment reform initiatives. The first one is hospital readmission penalty, which we are all familiar with. The interesting part is when it first came on, back in 2013, most hospitals believed they will not be subject to the penalty. And yet, as you can see, with each coming year, more and more penalties have been levied on hospitals because their readmission rates are not where they should be. And in fact, Medicare continues to expand the readmission rate penalty on additional diagnosis groups, as you can see here in the bottom. The interesting part with readmission penalties, of course, the hospitals are being penalized for things that occur outside of their walls. Something to think about. In addition to that is Medicare has also set in motion a value-based purchasing program for hospitals. It's been around for quite a while, in fact, since 2013. And similar to hospital rate readmission, a lot of hospitals truly believe they will not be subject to this penalty. And yet, as you've seen, the penalties continues to rise with each passing year. In fact, as of last year, a lot of hospitals have acknowledged receiving million-dollar penalties just on this payment reform initiative alone. And what the hospital value-based purchasing program is really tying a hospital incentive on 4 value-based metrics. One of them being efficiency, which is described here as the Medicare spending per beneficiary. And again, what that is that the hospitals are being penalized on spending that has occurred after a patient has left their walls. So I think you're starting to see the theme here. Then we move on. So we started with the hospital, and in fact now Medicare is also introducing value-based purchasing for the SNF. This will take effect in 2019. What it is that based on a calculation of a 5-star rating, a SNF will get a 2% Medicare rate reduction based on that calculation. The interesting part is that Medicare said for the first time we are going to calculate your 5-star rating on additional metrics. 3 of them are using claims data. This is something Medicare has learned a lot over the past couple of years with all the payment reform initiatives. And specifically, claims data in terms of a SNF being measured on a 30-day all-cost readmission, a 100-day community discharge, and a 30-day outpatient ED visit utilization for all the patients that get admitted to a SNF. So as you can see, the theme here is that Medicare is expanding the mindset of we are going to hold you accountable to delivering an outcome after a patient has left your building, whether you're in a hospital or a SNF.
So the next set of payment reform initiative, and this is a pretty big one, is what Medicare calls bundle payments. It's really moving away from a fee-for-service model, which is where we're at currently, to a situation where Medicare assigns a bundle price on a patient, and Medicare holds someone responsible to that price. And if you are over that target, Medicare will penalize you for that. And if you're under that target, Medicare will reward you for that. And this bundle payment, as you can see the theme, is a very broad period. It can cover as much as 90 days of an episode, meaning 90 days from the time a patient gets admitted at your facility. Bundle payment has been around for quite a while. In 2015, there was a wave to a bundle payment, and here are the specifics of that. The cost savings has been so promising for Medicare that they then moved to a mandatory bundle, CCJR. Of course, now we just call it CJR. And you may or may not be in a market that's impacted by that.
And same thing, the promise of bundle payment for managing Medicare costs is so good. Medicare actually then came up with another mandatory bundle called cardiac bundle. It should take effect towards the end of this year or early next year. More markets are affected. And last but not the least, if you're someone who understands your opportunity in bundle payment, Medicare will open the voluntary period for bundle payment again in 2018. That means if you're not currently in a bundle payment program, Medicare will actually allow you to participate in it in 2018. And again, if you knew the opportunity you have on that, it can be a very rewarding program. So with all the initiatives going on in the Affordable Care Act, in payment reform, and not only in Medicare payer, but particularly in Med-Advantage payers as well, how providers have reacted is they've reacted in multiple ways. Care redesign, implementing protocols for care transition, for care management, for care coordination. One thing that is very common though is that overwhelmingly providers, whether you're a hospital, a physician group, an ACO, and on rare occasion, whether if you're a skilled nursing facility bundle payment, they responded by narrowing their network. And here's a couple of snippets that are out there. If you do a quick Google search, you're going to find dozens and dozens of articles around narrowing networks. Why are they doing it? What's the logic behind it? What's the mechanism for it? In a nutshell, people narrow networks because of this. On a sample market for which we gathered claims data for, here's an example where there are 241 patients in a bundle. If these patients went through 12 SNFs that are currently being used, the risk owner would save this much. But if they narrow the network to 9, meaning they just got rid of 3, their savings more than multiplies by 4-fold. And this is the main driver for why people are aggressively narrowing network if they are involved in some kind of payment reform initiative. The dilemma, of course, is that if you don't have the data, you don't even know the decisions other people are making that may have an impact on your census, on the patient flow volume that's going through your building. Hence, when we started the webinar, we tried to frame the idea of risk and opportunity. So to mitigate the risk, the risk of not knowing, all these things are happening in my market, and yet I don't know how it's going to impact me. I don't know if my metrics are good enough to be included in narrow networks. I don't know if my metrics are bad enough to be included in a narrow network. What we like to do now is share with you the solution we've been developing over the past couple of months with the intention of sharing it to all our Infinity customers so that we can better assist you in participating in payment reform initiatives all over the country. And we call this our market intelligence data. Essentially what it is we've purchased claims data, we've assembled claims data so that you as a provider, whether you're a hospital, a SNF, or a home health agency, can make an assessment what is your risk and opportunity for value-based reimbursement initiative. And to really show how the data can be used is let's do a case scenario where we have a SNF provider in Salt Lake City and they are faced with this situation and they would like to know what are my options in this market given my market conditions. The market conditions being one of their primary providers, an ACO, 300 physicians that have very aggressive Medicare spending per beneficiary targets. Now that ACO, majority of their patients come out of a hospital for which this SNF is not a preferred provider to. The problem is that this hospital has not bought into a narrow network strategy. And then of course here we have our independent SNF B who have undergone a recent physical plant update, spent millions of dollars. And yet on the flip side, what they've seen is that their length of stay have shrunk, referrals to SNF have shrunk, leading to a slightly creeping higher, lower occupancy rate. And this SNF, on the other hand, competes with 9 other SNFs, and they believe they are the better SNF. And this is just something they believe. And last but not the least, there's a home health partner that's willing to put all these things together. So what we'll do is kind of paint that case study using the market data we have set up. So here I go to Utah, Salt Lake. St. Mark's is the hospital that we have in our case study. And in this dashboard, what you can see here is these are the peer group for the hospitals. These are the outcomes measure for the group, their 90-day readmission rate, 30-day readmission rate, and mortality rates. This is the 90-day cost of care. And this is the discharge pattern. So first thing we want to know is this hospital in question better or worse than the market? If we just selected that hospital, in fact, what we see is that their readmission rates are worse than the market average. So as you can see, the ACO was right into believing, you know what, I'm worried about this hospital because I'm at risk for managing my costs, and yet this hospital does not have their act together. So we see that. Secondly, how about if we just look at CJR? So here's the market average, and let's just click on the hospital. Again, this hospital is slightly above the average, and this is CJR market, so opportunity number 2 is that now we know this hospital is going to have struggles with CJR. What can we do about it? Last but not the least is let's just look at the SNF, meaning let's just look at the episodes that go to a SNF after leaving a hospital. And again, here are the metrics. And I'm going to select all patients again. And I'm going to click on that hospital again. So on the flip side, this hospital actually has better metrics than the peer for the patients they sent to the SNF. And in fact, here you can start seeing, well, which hospital is worse than the average then? This hospital is worse. This hospital is worse. Hospital is worse. And now you have your better hospital. So now this is just one side of the equation. Of course, this is only an opportunity if the SNF actually knows what their metrics are compared to the hospital and what their metrics are compared to their competitors. Again, using market intelligence data, we are able to do that. The SNF on the black bar is the SNF we are talking about. Here's the SNF who's struggling with census because they're not in a preferred network. The facility on the red bar is the hospital LTAC or IRF. So what we're doing now is we're trying to compare all the SNFs that compete in this market. So first off, let's just click on the SNF we are referring to. And as you can see, the reason they're not in any kind of preferred network, because if someone checked their data out, in fact, their readmission rates are worse than the market average. Now the SNF has an explanation for why is it that I'm getting fewer referrals. But also on the flip side, there's an opportunity because this hospital is sending a lot of their patients to their own IRF. And as you can see, the hospital's own IRF has bad metrics, readmission rates. So is this an opportunity for Legacy Village to have a conversation with the hospital into saying your patients are better off if you send them to me? And in fact, if you look at the metrics of the other SNF peers, what you will find is that there is one very dominant SNF called Highland Care Center that is on a preferred network. But for some reason, they're actually not the best SNF from an outcomes point of view. So then again is opportunity for our SNF partner to have a conversation with the hospital saying, hey, do you know that you are sending your patients to a SNF that might not be the best for your pay for performance metrics? And similarly, at this point, we can also look at CJR patients. So on the good note, the SNF, our partner, have really good CJR metrics, as you can see for their readmission rates. The hospital IRF is worse than the market. And this is one of the dominant SNFs. This is a preferred network for the hospital. Again, actually pretty poor metrics. But no one knows this because the challenge with claims data is that only Medicare knows what is truly happening in the market. Of course, unless you invest in putting it together, then you may be in the position to do that. And that is what we have chosen to do as a resource to the Infinity customers. And in fact, here's a picture where we're putting all those together so that now we are able to compare the hospital metrics with the specific SNF we're referring to in comparison with all the SNF competitors in the market. So I'm going to pause here now and just transition back to my closing slide. And then we can open up the question. So in brief, what we really like to cover is that in value-based reimbursement, there are risks built into it. But those risks, if you know your information, your data, will present opportunities that you may be able to pursue and secure census in your market. The question we ask is, how much of value-based reimbursement or payment reform are you seeing in your market? Are you at risk? Meaning, do you know how it's going to be impacting you? Do you know how you compare with your peers? But more importantly, do you know your opportunity for doing something, for taking advantage of this? Whether you want to be in a preferred network, whether it's managing your 5-star rating when 2018 comes in for value-based purchasing, or whether when CNF opens up voluntary participation in the bundle payment program again. That said, what I would like to do now is open it up for any questions you may want to ask during this call. So I'm putting everyone on speak mode. So if you do have a question, we encourage you to please go ahead and do so. Hello?
So the data you were showing for the goes back to Q4 2014. How often is that data updated?
That's a very good question. The data is only updated by Medicare once a year. However, that data is a very big data set. So what we've done is every quarter we've prepared it a different way so that you can get more information from the data set that's coming from CMS. Did that answer your question?
Yes, thank you.
Okay. Any other question on anything we went over so far? Okay. So I have a question here from Mark Scharnberg. How can we as customers access the tool? That's a very good question, Mark. Slowly, what we're doing is we're integrating this into the ARD quarterly business review routine. So the ARD assigned to your building is being trained how to access this data and how to read it. of course, instead of waiting for your ARD to come to you and schedule that, we can also encourage you to reach out to your ARD and tell them, you know what, I would really like to sit down with you and understand that market data, and specifically understand the market data for my specific market. So hopefully that answers your question, Mark.
And hi, this is Ty Keeter. I'm actually in Kearney, Nebraska right now, and just reviewed this data for the Kearney market for the Good Samaritan, St. John's, and St. Luke's communities with the administrators and RVP for Good Samaritan here in Nebraska.
And how was that experience for them, Ty?
It was enlightening, to say the least. It was enlightening because they got to see what the hospital is looking at as they narrow their network.
Great. And you know, Ty, that's a good point when you say they get to see what the hospital is looking at, because the reality of this is that hospital being in some kind of reimbursement reform model, whether it's ACO, bundle payment, CJR, or value-based purchasing, Medicare actually supplies claims data to the hospitals. And the hospital will see data for all the SNFs and home health agencies in their market. And they're making decisions on it. The downside is that this data is unknown to the skilled nursing facilities and home health providers for which the hospital is making decisions on. So that's the scary part. Okay. Any other questions from folks on the call that you may want to pose or ask the group? Okay. I hope silence means I've got a lot to think about. To that point, what I want to do is, if Mike Billings is on the phone, I would probably like to hand it back to Mike Billings. Okay, it seems Mike is not available. What I'll do is I do have our VP for Network Development beside me, so I will probably let her put some closing thoughts to everyone that has attended this call.
Good afternoon, everyone. I'm really happy that you all joined us. This session was recorded and will be available for further review. We will send out a link to all of you, as well as those on the mailing list, so that you can access this at a future point. I want to thank Jake for the amazing data that he has put together for our customers, and for the presentation today that tells us what we don't know can indeed harm us now and in the future. With that, bookmark every Tuesday at noon Pacific time for another lesson in transforming to value-based care. Thank you all very much, and we'll see you next month.